again, remember, Brittany helped us pick these because we asked everyone, what kind of new publications have changed what you do in your hospital? And we got feedback that several hospitals have changed their gastroschisis protocols based on recent publications. So with us, we have Beth Rymeski, Jason Fraser, and Stephen Lee, who are going to talk about updates in gastroschisis.
Great, thanks, Todd. So I have the easy part. I'm just going to put up the poll question. Welcome, everyone. So we are going to address 3 topics. The first will be when to start feedings, using a feeding protocol, and what to do when you start feeding and your baby with gastroschisis starts vomiting. So our first question is, you just performed a sutureless abdominal wall closure in a newborn with gastroschisis. The bedside nurse and family ask you when you want to start feedings. You reply. So we'll put up the question.
All right. So go ahead.
So you have 4 choices. Immediately after sutureless dressing is placed, when the OG output is clear, when the OG output is less than 10 mLs per kilo per day, when the abdomen is completely closed, defect is covered by skin and fascia.
All right, guys, you're not off the hook. I'm going to be calling on you. When do you feed a gastroschisis baby? When do you feed? Right away? Do you put the tape on? Do you wait or you just start feeding right away?
What did you say?
What'd you say?
When the output's going down.
When the output's going down, says Miguel. Justin.
We have a protocol. I don't remember the exact number. It's not based on what the OG looks like or NG. It's just volume. And then
So it's NG volume. Mira's nodding her head. NG volume, same thing? 20 per kilo. Once it's less than 20 per kilo, you start feeds. Take out the NG. Anyone different? All right, Steve.
Okay, let's take
Wait. What do the polls say?
Poll question say?
Sorry, Steve.
It's split between when the OG output is clear, that's about half, and then the next up is when the OG output is less than 10 per kilo.
Okay, I'm going to go out on a limb. I would have said B myself because we do consider quality and quantity, but I think we're going to hear something different. So, Jason?
So, why do you do 20? For those that said, like Miguel, what does it mean by you with decreasing?
And then it's going to 60. The third day, I must start doing something.
Okay, so do you pull the NG then?
No, just keep it closed though.
And then when do you?
Sure. Yeah, every 4 hours something.
Okay, why?
To see how it's going.
Okay. So I mean, again, there.
Get much more of that out of him.
So I mean, there's trying to go back. How do you go? There you go. Okay. So we start, and we're pretty aggressive. So we start feeding essentially after you put the dressing on, as long as the baby's not sick, not having horrible output, not puking or anything like that. There's been several protocols that have been published on this, and it's kind of all over the place. You know, some say 20, some say when the baby's had a bowel movement, some say when the output's kind of clear. You know, some say when you clamp it or you stop it and there's output and it's doing okay.
Immediately, and in whatever, but means if the NG goes to 100 in one time, completely very dark green, videos brain.
So well, essentially, we don't intubate our babies at all. So we put the plastic dressing on, and as long as the kid's not has voluminous output, we'll try to start feedings on it if it'll tolerate it.
Can I interrupt you for 1 second?
Yeah.
Before we keep going on this,
yeah.
You've already put the dressing on.
Yeah.
I want to ask a question about the dressing for 2 seconds. I'm going to be the outlier here. You're going to throw tomatoes at me because I don't understand. Why is everyone pushing for no sedation when we put the dressing on? Yeah. I think it's going to hurt us. I think we're going to have better outcomes with more sedation. But you intubate.
Yeah.
Who intubates? Just Miguel, Cecilia. I would love to. Dan threw his hands down. I think it's much harder for me to get everything down.
For you or for the baby?
Against me. What's that?
Is this for you or for the baby?
For both.
Yeah. For the reduction or for actually putting the dressing on? I don't understand what you're asking.
Well, in order to put the dressing on, you need to reduce, right? So I'm pushing it in and the baby's crying and it's popping back out, and I'm pushing it in, the baby's crying and it's popping back out. Maybe I'm the only one that has that issue. And when they're sedated, it's like, doop, doop, doop. easy.
It does. And I think what we've learned by doing this more and more often is that if you try to just keep pushing and pushing and pushing, the baby kind of can squirm and stuff. But if you go slow, if you empty out the stomach, if you kind of squish out the colon a little bit and you go slow, you give the baby some sweeties. The nurses are there to kind of relax the baby. You have a couple people that are there doing it. You go slow and you slowly kind of push things in and you stretch out the belly a little bit. They do okay.
Question, and Bindi, hold on, wait 1 second, hold on. I have the microphone right now. You have to come grab it from me.
Yeah.
Okay, but
well, yeah.
Real quick question. Bindi, do you sedate an IND? At your hospital, do you do them awake or sedated?
Oh, fully general anesthesia.
So you do a general anesthesia for an IND,
Because
but shoving bowel inside a newborn baby, no, we're not going to give them any sedation.
I don't think there's any nerves.
Oh, they're going crazy.
It's just the pressure that bothers them.
Yeah, it's the J receptors. It hurts.
Yeah.
Anyways,
I mean,
all right,
I don't know.
keep going. I'm going to throw us off.
So no, this is an important good thing because everybody's so different on the way that they do this. So I mean, even the way that people use feeding protocols is different. Ours is pretty aggressive. We just started this one recently, so we'll have some data on this probably in the next year or so. But it's really just based upon patient tolerance, and it's kind of based upon some of the data that's out there from the rest of the world where they don't have TPN. And so you have to feed the kid, and if the kid does okay, then they keep going. Whereas, in the US, we were such privileged that we have PICC lines, we have TPN and things like that. And so this is, ours is really kind of based upon that as well. I mean, Beth, you want to talk about kind of what your protocol looks like a little bit?
Ours is yours, but more complicated. So I think we have the slide thing. So our feeding protocol came about by looking at outcomes, and I think maybe that's the next slide. No. We'll get to that. But ours is talking about the same thing. So it's basically once the dressing is on or the abdomen is surgically closed, which almost never happens, then it goes by volume and talks through some things. And then we have a standardized increase for the feeds. And then I think we have also on here, we introduce sham feeding because what we realize is a lot of our gastroschisis babies have very poor oral feeding skills from, delayed access to feeding, etc. So we introduce sham feedings and we advance sort of per protocol. Before this, we had trialed a system of just ad lib feeding. It was not successful. I think there were a number of reasons for that. Part of it was that there was no standardized plan for when to get the NG tube out. So I think we started feeding these babies too late. And what we did for 2 weeks was we just let them ad lib feed and we filled in the rest with TPN. But we abandoned that after about a year or so after we looked at the results and realized that wasn't working. So this is the practice change and protocol that we've had in place for I think the past 4 years or so. So I think the next question we had was, does your institution have a gastroschisis feeding protocol? To kind of get a sense of worldwide, what the practices are. So A, yes, and I follow it. B, yes, but I don't follow it. No, or unsure. So in the room, how many people have a gastroschisis feeding protocol at their institution? So it's like 2/3 of people. How many of those people follow the gastroschisis feeding protocol? So it looks like we have a lot of followers in this room, so that's maybe good. I don't know if we've had enough time to
so far
comments.
So Beth, I think that this is a general statement, but the reason these protocols, at least in my opinion, are important is because there's not variation in care. Generally speaking, they've been tried and true and work all right, but the nurses know what it is, and you don't need to call a doctor every time you want to increase by 10 cc's or whatever. So that's why I think all these protocols, whether it's gastroschisis or anything, are important so that your nurse practitioners and your nurses and your residents just know what's going on and how to feed or manage these patients.
Yeah, I think that's a really good point. Ellen, what does the poll tell us?
Yeah, it's most people, half of them are saying, over half, yes, and they follow the protocol as of now.
Well, there we go. Lots of followers. So does it really matter? So Jason was the lead author. I guess I'm going to present this for him, of a study that we recently published out of the MWPSC about outcomes of patients who were and were not fed by protocol, where it was roughly 2/3 by protocol, 1/3 not. The protocol-fed infants had fewer surgical site infections, which, and then we weren't really sure. There was a lot of differential variations. I don't know if you want to comment on.
Yeah, I think a lot of the inconclusivity from the study showed that, you know, most likely due to the fact that there was lots of different feeding protocols that were used across our member institutions, and I think the SSI thing was probably just because patients that were fed via protocol were cared for via protocol, and so that they actually had less variability and less changes in the way that these patients are looked for. And I think this kind of speaks to the fact that, number one, there's a lot of variability within gastroschisis in and of itself when you get cohorts that large, but then number two, even if you have different protocols, there's significant variation within and of itself in that too.
So I think just one of the things, and I alluded to this before, the reason that we started looking at these is our length of stay for gastroschisis in Cincinnati was astronomically higher than like any other NICU in the cooperative network that we worked with. So we sat down and we're like, what is going on here? So our average length of stay was 49 days, and it was comparing to other NICUs like Kansas City and other places that are taking care of very similar babies. It wasn't like it was comparing to a different type of NICU. So we instituted this a feeding protocol. We spent a lot of time trying to get people to follow it and making some adjustments. And over 2 years, we dropped the length of stay by 10 days. And the mix of patients is not different. So I think it can work. There's a lot of other things obviously going on here that we're working on. We're finally starting to see a decrease in time to first feed to full feed. We haven't really seen the number of days from admission to first feed change, although 2020 we did really well and then bounced back. But so we're working on that. But I think it can sort of standardize care and make things smoother.
Sure. Third question. After 2 days of successful feeding advancement, the baby has one bout of bilious emesis. Now what? What do you do with your feedings now? NPO for 24 hours, NPO for 6 to 8 hours, keep feeding at the current rate and volume, decrease feedings, the volume and rate. So as this is coming up, I'd love to hear from the room here what people would do. Keep going. Keep going. NPO over there.
Justin?
Put a chest tube in, is that what I heard? Oh, wait.
Justin?
I have a question. So I love the protocol because it allows us to sort of fade into the distance, and the NICU can mostly run it. But the downside of what I've seen from doing that, of us not being that involved, is there's like this tendency of the neonatologists, some of them love like continuous feeds, and then they're not taking anything orally, and then a lot of them get oral aversion, and that prolongs their length of stay. Do your guys' protocols say how to feed, bolus, when they get oral, that kind of thing? Because that also significantly contributes to length of stay, not just getting to goal feeds.
You're right, and that's why we do try to do both intermittent feeds to start, but it doesn't specifically say you have to. But I think that's where the sham feeds are. Hopefully, we'll see. It's too early. We've only been doing that for like a year to see if maybe that is going to make a difference, because our rate of sending gastroschisis babies home with an NG or a G tube, it's like 2/3 of them go home with some sort of tube to help them continue feeding, which is crazy. But yeah, I think that's true.
Ours does include how to feed, when to feed, how to advance, all of those things. We actually took it for the prenatal care for our whole gastroschisis protocol, including our OB-GYNs, and then with a neonatologist to help post-operatively. So we continue to follow. I think it is key that we do continue to follow these patients throughout their duration. Okay, what did the polls show?
It's been changing a lot, but it's pretty divided. Currently, it's about equal between A, C, and D.
So if it's equal between A, C, and D, probably B also. So it's all over the map. So is it Jason? You're going to tell us what we do next?
So, Steve, is the question about bilious emesis or is it about emesis? Because I think I think that may or may not be impactful on what the answer is. Right. So I just didn't know if that was why there was variation in the answers.
Yeah, I put that bilious to stimulate this because some people will ignore bilious emesis completely. Some people check residuals, and that's going to be bilious a lot of the time too, and some people will just completely ignore that. And I think that's the important, we were talking about, Miguel was shaking his head, just keep feeding. But I think that's an important thing to say too. But the most important thing I think about all of this is, like Justin was talking about, how we kind of start fading away, is actually not fading away. A lot of the protocols that are out there talk about, there's this one study from New Zealand talks about the attitudes towards feeding. And it's a little bit different, but the most important thing that kind of keeps showing up is the fact that we really need to define what your own institution has for tolerance and to kind of stay on the protocol. And then really just look at the infant condition as you continue to go is the most important thing. Yes, you can have a protocol. Yes, you need to follow it, but you really need to continually evaluate the patient as they continue to go to make sure that, yes, your protocol is working, but also too, the patient does okay throughout. And that's essentially what this does. For us, if the patient really has significant issues in complete intolerance, we'll stop for 6 hours. But again, that's, necessarily this isn't clearly evidence-based at this point because there's still so much variation in the literature as regards to that. But we did put in our protocol for our nursing colleagues as well as our families that emesis is expected. So we put that within our written protocol to make that expectation known that it's okay. It's okay that they're going to throw up. We'll just keep working through it.
How quickly do you get to goal feeds on average?
Yeah, good question. So with our new protocol, we started just really instituting that in last May, and so we've had very few patients with that. I can talk about one of our last patients that we got primarily reduced, day of life 0. He was probably out of the hospital in about 2 weeks, and I just saw him back in clinic about 2 weeks after that, and still doing okay. That's probably an outlier in the quicker side. Gastroschisis length of stays has probably been about 30 to 34 days or so. And so hopefully keep inching that down. And so we really try to push oral feeds quickly to get rid of that oral aversion issue. And I think the quicker you can get to that, the quicker it's going to be able to get them home.
And do you start with a tube in place at any point or just like for
we
reduction?
Start with the tube, but then try to get to oral feeds either both with the tube or without it.
With your early feeding, I'm sorry, I missed how quickly you start once they're reduced. Is it 1 or 2 days? Right away. Have you seen any aspirations?
Have not yet, but again, we're still pretty early. We have not seen any aspirations with regards to that yet, but we're still pretty early within that. And I think that's the importance of continuing to monitor the data.
Yeah, and I think this is really important also for low resource countries, right? Because they don't have TPN, and I think this is where a lot of this data came from, is started in sham feeds and early feeds in those kids. But having tried that in Africa a few times, it is very hard for those kids to tolerate that. So just interested to know what your approach, how it leads, and would be very helpful.
Yeah.
Jason, what are you doing with the patient you cannot reduce?
So if we can't reduce it right away, probably at least 2/3 of them we can't reduce right away. We put them in a silo and reduce there, and then do sutureless gastroschisis closure after that.
And then you start feeding.
And then we start feeds, yeah.
Okay.
All right. This was a great session. I love this. It's short. It's to the point. I think that we've seen, to Bindi's point, this is a big problem internationally, and the more we can figure out how best to treat these, the better. We have really great sessions coming up. We're going to be talking about the most cutting-edge new technology in the past year in pediatric surgery or surgery as a whole. We're going to be talking about which patients, I know they tease me because I'm not good at this, which patients can you send home from the emergency room? Because I admit everybody. So who can we send home and feel okay about it? And then we're going to be talking about new ways of managing esophageal leaks. We've all done it the same way for years, so we're going to get to that. But I want to make one plug to tell people about all this talk of protocols. So the Stay Current app, I want to give credit to Mira Kodagal, who came up with this idea of creating a private space to keep these protocols in your hospital. It's all with your hospital videos, your hospital protocols, your lectures all in one place. But the cool thing that just happened, and probably most of you here already have done this with us, is the idea of creating your hospital space and a sharing network. So that if you're part of the network, you can share protocols and see what all the other hospitals are using, ask questions, move them into your list, your playlist of protocols, and get updated when other hospitals are making changes, because I feel like we're all kind of on islands and we do things different. So hopefully this will end that. So let us know if you're interested in that for your hospital. So we're going to take a quick break, talk about O'Shea Buffalo Children's Hospital, who has again been with us from the very beginning for 10 years now. Mac Harmon is the chairman of surgery there. So let's roll that video and then we will come back.